that we talked about before to distinguish some of these different diseases. We're going to start off with severe combined immunodeficiency. Now, this is probably one of the highest yield overall. When we're talking about SCID, or severe combined immunodeficiency, we're talking about involvement of both B and T cells. And so in your mind, when you're thinking about these different pathologies, you want to ask yourself, are there T cells involved and are there B cells involved? And if there's T cells involved, we know it's going to have some impact on cell-mediated immunity. Okay, because we need T cells, cytotoxic T cells, to destroy cells displaying antigens on MHC1. And when we're displaying an antigen on MHC1, a lot of times that's going to be a virus, right? An intracellular pathogen that's infecting that cell. And we talked about all of this in the last few videos, so I won't go through all the details on it here, but check out the last few videos. If you're a little confused by any of this, we go through all of the basics there. If I knock out my T cells, I'm going to knock out cell-mediated immunity. So things like viruses, for example, will actually favor this. Viruses are going to have a really easy time infecting our cells if we have poor cell-mediated immunity, right? If I knocked out my T cells, for example, because then I don't have cytotoxic T cells to then go and destroy cells that are displaying the virus antigens on MHC class 1. The other thing I need these T cells for is I need T cells and B cells to come together, right, so that I can generate class switching. Okay, so I can change the heavy chain on my immunoglobulins. Remember, most immunoglobulins are going to be IgM. But if I want to generate a memory response with immunoglobulins like IgG, for example, right? If I want to use IgG, I'm going to need to have class switching. Okay, so memory response can also be impacted if I knock out my T cells or my B cells, right? And the same concept is true when we talk about antibodies like IgA. I need IgM to class switch to IgA so that I can fight off things like certain parasites, right, that are going to be in the GI mucosa, where I'm going to have a lot of IgA. Things like Giardia, for example, are going to flourish in patients that have some problem producing IgA. And then, of course, we also talked about IgE being in this category. And in general, if I knock out my B cells altogether, I might also impact some of my humoral immunity just in general. So when I think about IgM, IgG, IgA, IgE, all of these might have some impact. I might have a pan-hypogammaglobulinemia. In other words, I might have a decrease in all of these immunoglobulins if I knock out my B cells altogether. And so the point of this is just from looking at this, right, you can kind of say, okay, look, I went through all of the physiology, I understand the mechanisms here, so all I have to do is figure out, okay, what's the problem? If I know what the problem is, right, if I knock out this T cell, well, guess what? I'm not going to have great cell-mediated immunity. I'm not going to have T helper-dependent antigens because I don't have B cells to bind to T cells with CD40 ligand because my T cells are knocked out, right? Even if I have functional B cells, that might be a problem with class switching and generating a good memory response. Because remember, not only do these B cells undergo class switching, but these B cells will also undergo affinity maturation as soon as they bind to these T cells and then get activated. And let's talk about some of these different pathologies. So again, going back to severe combined immunodeficiency, the thing that you want to know here is there's really a couple different, reasons that this disease comes across. And this is the big thing. When you're talking about step one, you got to know your pathophys. What's causing each of these diseases? So with severe combined immunodeficiency, the classic defect is in the interleukin-2 receptor. Now, this should make some sense to you, right? We talked about interleukin-2 in the cytokines video. You can go back and check that out. But the point there is that interleukin-2 receptor is very involved with growth of lymphocytes, right? It's very involved. You can even have autocrine signaling with interleukin-2. If you remember from that video, we talked about that. That's kind of the high yield thing to remember. You can have all different types of signaling, autocrine, paracrine, endocrine signaling from interleukin-2. And this allows proliferation of lymphocytes. So guess what? If this is defective, if those receptors are defective, I'm going to have a tough time mounting a strong immune response and generating the necessary T and potentially B cells. And this is the most common mutation that you'll see in SCID, and the classic inheritance pattern here is X-linked recessive. Now, you have to kind of juxtapose that to adenosine deaminase deficiency, which is autosomal recessive. And the difference here, the pathophys is completely different, right? Because interleukin-2 is responsible for T cell growth, right? So the interleukin-2 we talked about, this is primarily responsible for the growth of lymphocytes, right? So we're thinking lymphocyte growth. And so that's why if I knock it out, I'm going to have a very tough time mounting a strong immune response, or at least having lymphocytes that are going to be able to fight off my infections. Now, with adenosine deaminase deficiency, the difference here is that, remember, what adenosine deaminase does. So let's just say I have some adenosine, okay, maybe some deoxyadenosine here. So these substances can get converted to hypoxanthine, okay, this is going back to your biochem, as well as uric acid by adenosine deaminase, right? ADA, I'll just put for adenosine deaminase. So adenosine deaminase converts these substances to hypoxanthine and uric acid. And the whole point of this is so that we can eventually just excrete these substances in the urine, right? Kind of as waste products. So these can just get excreted from the body. Okay, so this is part of your purine metabolism, purine breakdown. Now the thing here is, if I don't have adenosine deaminase for whatever reason, let's just say I don't have adenosine deaminase, now I'm going to have a buildup of deoxyadenosine and I'll have a buildup of adenosine. So why is a buildup of this deoxyadenosine and adenosine a problem? Well, if we go kind of backtrack a little bit, so remember you have your ribonucleotide reductase, which essentially is going to take ribonucleotides and convert them to deoxynucleotides. The point of this is essentially we want to take our ribonucleotides that we might use for RNA, for example, and we can convert the sugar group that we can use these structures in DNA. That's the point. So ribonucleotide reductase is going to generate deoxynucleotides. Now, deoxyadenosine is an example of a deoxynucleotide. So if I have a whole big buildup of this deoxyadenosine, for whatever reason, let's just say adenosine, right? If I have a whole bunch of this deoxyadenosine, what's going to happen is this is actually a product of ribonucleotide reductase. So it's going to have negative feedback on ribonucleotide reductase. Okay, and so this buildup of adenosine is going to inhibit the conversion of ribonucleotides to deoxynucleotides, which is a problem because then I can't use all of these ribonucleotides for DNA synthesis, right? I can't make deoxycytosine, I can't make deoxythymine, right? I can't make the other deoxynucleotides because I have this massive buildup of deoxyadenosine because I couldn't convert it because I don't have adenosine deaminase. And so we see a precipitous drop overall in the deoxynucleotides because of the buildup of deoxyadenosine. That's the point. If you think about lymphocytes in a newborn, for example, we're producing a lot of lymphocytes in that time period, and there's a lot of DNA that's required. And if I don't have the tools to make that DNA because I have low deoxynucleotides overall, right, then I'm not going to be able to make enough immune cells. And so adenosine deaminase is very classic for having a low B cell and T cell in the serum. Both of these are going to be extremely low in the setting of adenosine deaminase deficiency. Okay, so you can imagine if you knock out T cells and you knock out B cells because you can't make enough DNA to correctly make these cells, then there's going to be a whole host of problems, right? Everything under the sink, so to speak, is going to be involved. So that's adenosine deaminase deficiency. So completely different mechanisms, but they're both causing a similar variant in that we're affecting multiple cell lines and that we're affecting T cells and B cells potentially. That's the point here, that we can affect T cells and B cells. Now, the last thing on here is RAG mutations. I'm not going to go into too much detail on this, but remember we talked about what the RAG gene does. It's the recombinase gene that allows you to kind of shuffle some of the information in the cell so that we can produce different types of cells, right? All of that variation that we talked about. And we talked about this already in some detail. But again, these are the three classic causes. The two in particular to remember are going to be a defective interleukin-2 receptor, right? The lymphocyte growth receptor, and adenosine deaminase deficiency. Now, how does this present? Normally, in a lot of these different pathologies, we're going to have a normal newborn. Why is that? Because remember, the IgG antibodies can cross the placenta. So you can actually still have mom's antibodies as a newborn. And so you can still fight off some of the infections because of what you have from mom. But over time, what's going to happen is those antibodies have a half-life, and those are eventually going to start to come down. And so these children will often have failure to thrive, recurrent infections. Typically, this is going to be a younger patient, around 6 months to 12 months of age when this initially gets diagnosed. You can also see absent lymphoid tissue. Now, the point here is you want to be kind of sharp on, what in the lymphoid tissue is involved. Let's say I biopsy a lymph node. Okay, let's say I biopsy a lymph node and I tell you that, hey, this lymph node has little to no follicles or very small follicles or very small germinal centers, for example. What am I basically telling you? I'm telling you that the B cells are primarily involved, right? Because that's where the B cells are going to live. There's going to be dormant in primary follicles, active in some of the pale staining areas of the germinal centers, right? And so this would suggest potentially that B cells were probably involved, right? Now, on the other hand, if I told you that, hey, the paracortex is absent or hypertrophied, for example, a very small paracortex, we might be talking about T cells. This all goes back to the first video where we had to understand, where do the B cells come from? Where do the T cells come from? And so it's kind of integrating that information. So you can get this information. You can get them telling you that they biopsied a lymph node and there's, very small follicles, low paracortex, absent lymphoid tissue. This is all very classic, pushing you in the direction of a B and T cell disorder. And conversely, you can have a normal paracortex with very small follicles. And in that situation, you might be thinking maybe this is more of an isolated B cell scenario. Okay, so we'll talk more about that. But again, I don't want to get too off track. So in terms of the diagnostics here, the big one to remember are these Tregs. And so So the Trec stands for T cell receptor excision circles. And I'm not going to go into, all of the detail on this. This is one of those things I would just remember specifically for severe combined immunodeficiency, is that you can test for this using Tregs. And this is actually frequently done in the newborn screening. So they'll do, an assessment to look for SCID by trying to measure these T receptor excision circles. And they're going to tend to be very low. And part of that makes a lot of sense, right? You know that the T cell count is going to be low. And so this being some surrogate. The other thing you can classically see here is an absent thymic shadow. And this is not just something that you see in severe combined immunodeficiency. You can also see thymic hypoplasia or thymic aplasia in general when you're talking about DeGeorge syndrome, for example. Point here being when you see absent lymphoid tissue, right, paracortex, follicles, right, you're also expecting your thymus, which we already said is part of the lymphoid tissue. It's where the T cells mature. That's going to probably be absent if I don't have T cells, right? And so if you did flow cytometry, you would see very low numbers of T cells. And we already kind of showed that flow cytometry graph kind of earlier in the series, where you can kind of have two lines going each way, and sometimes you'll see a bunch of dots on there representing certain cells. And so sometimes you'll see, a CD marker, it'll be CD, and then some number here that would represent that this CD marker is present in your flow cytometry sample. And then you'll have another one here, right? And so this one, you might see no dots here, or you might see dots up here, meaning that it has a combination of the two, for example. But the point is, you have to know these CD markers to understand these flow cytometry graphs. So for T cells, right, what's the classic CD marker that you want to be familiar with? You really want to be familiar with CD3. Okay, so CD3 is going to be pretty much on all of your T cells. So if I gave you one of these graphs, for example, right, and I said that, okay, this person's CD3 is here, maybe they only have a dot here or a dot here. They have very little CD3 detected in that sample. Well, that will tell you that the T cells are very low. That's something we would expect in severe combined immunodeficiency. You can also see extremely low levels of serum immunoglobulins of all isotypes. And the point here is remember, if I don't have functional B cells, or I don't have T cells that can allow activation of those B cells to undergo class switching, in those situations, I'm going to have low IgG, IgA, and IgE. And because, especially in adenosine deaminase deficiency, right, we're not going to have any B cells either. And so I'm not even going to get IgM. So all of these are going to be knocked out. So all of my immunoglobulins, all isotypes are going to be low. Let's say that you had a newborn and you're testing your immunoglobulins after the first couple days of life. Well, sure, you would expect the IgG levels to be relatively normal at that point, because remember, you still have mom's antibodies. But if we're talking 7 or 8 months out, then in a patient that has SCID, you would expect the serum immunoglobulins generally to be very low. Okay, let's talk a little bit about Bruton X-linked A-gamma globulinemia. How does this differ from severe combined immunodeficiency? The point here is, normally when we're talking about SCID, we said that there's probably going to be involvement of T cells, and in certain variants we can also have involvement of B cells. But the difference between the two diseases here is that with Bruton's we're just talking about B cell involvement. So our cell-mediated immunity should actually be functional in these patients. The issue here is primarily going to be with B cells. And if I don't have B cells, we're going to have major issues with our immunoglobulins. Okay, so B cells are going to be very, very low, and that's because this step, this BTK gene, allows for our B cells to essentially get out there into the circulation. So if I don't have this gene working, my B cells are not going to be able to get into the blood and eventually into the lymphoid tissue. And so my B cells, essentially, if I had some bone marrow here, right, so here's my bone marrow, my B cells are going to just be kind of sitting here in the bone marrow as pre-B cells. Okay, they're never going to make it out into the bloodstream, right? If here's my bloodstream, and then eventually maybe I have some lymph node, right, that these blood vessels are eventually going to kind of go into, right? I'm never going to be able to get these B cells out into the blood because I don't have this functional BTK gene. And so all of these pre-B cells are basically going to stay here, and in the blood, I'm not really going to have any B cells. And if I don't have any B cells, right, I'm going to have a hard time making IgM. I'm going to have a really hard time making any other immunoglobulins in general because I can't class switch, right? I'm not going to have B cells to bind to T cells to get activated to become antibody factories or plasma cells. Okay, so if I did flow cytometry on these patients, I'd see very low levels of CD19, 20, and 21. So what would that look like, right? So if I did flow cytometry on one of these patients, for example, right, and let's just say that this was CD21 and this was CD3, I might have, some level of CD3 that is normal, right? I might see a lot of dots representing CD3. And maybe I don't have any, dots at CD21, for example. And there's a lot of different ways they can show you this. But the point being, Bruton X-linked A-gamma globulinemia would be in my differential. And again, if you go back to the name, remember we said that combined and SCID kind of makes me think of B and T cells combined, right? But when I'm thinking of this name, right, I'm looking at A-gamma globulinemia. It pretty much tells you what's going on. A meaning without immunoglobulins in the blood, right? I don't have immunoglobulins, and why don't I have them? Because I can't get these pre-B cells into the bloodstream. Okay, and so that's why, again, if you know your CD markers, you can see a flow cytometry question, and you can say, look, I know there's no CD19, I know there's no CD20 or CD21, I know that my B cell levels are very low, but in some way, the T cells will be functional, right? They can show you CD3 on here, they can show you a lymph node and show you that the paracortex is completely normal, but there's, follicle atrophy, for example. Again, just putting all the pieces together with T cells and B cells like we talked about, you can distinguish these two different diseases with that information. And again, we just talked about this, all isotypes should be affected in Bruton's X-linked A-gamma globulinemia. I also want to talk about common variable immunodeficiency because it often gets confused with Bruton's X-linked A-gamma globulinemia because they're similar in that they both affect B cells, but they affect the B cells differently. Now, for most of these different pathologies, the presentation, it's going to be tough to just use the presentation to just say, okay, I'm at this disease or this disease. Usually, you're going to have to know a little bit about the diagnostics, the CD markers, the flow cytometry, what's affected, right? The pathophys. That's going to get you a lot of the answers on step one. But when you're talking about Bruton's and common variable immunodeficiency, the presentation actually can be relevant in that with common variable immunodeficiency, it tends to be less severe. And so these patients will typically present a little bit later in life. Usually post-puberty. The classic age range for questions is like between 20 years old and 40 years old. So if you have a patient that has recurring infections at 20 to 40 years old, and then they start giving you some clues that there's potentially very low immunoglobulins, right? You might be saying, well, could this be Bruton's? Well, probably not, right? Bruton's is going to be no B cells. And so these patients, as soon as they lose mom's IgG, they're going to start to present with symptoms. Whereas with common variable immunodeficiency, these patients will tend to present much later in life with low immunoglobulins and plasma cells. Okay, and the pathophys here is also a little bit different. With Bruton's, we were basically saying, look, we can't get any of those B cells out of the bone marrow, right? So we effectively have no B cells. The difference here is that in common variable immunodeficiency, we actually have B cells. We have normal levels of B cells. So on flow cytometry, we wouldn't expect to have no CD19 or 20 or 21 markers. We would see them. However, the issue is that we have B cells, but they don't work correctly. So the issue here is that we do have B cells here in the bloodstream, right? These are my B cells. So I have B cells, okay? I have B cells, but the issue is that they don't work. My B cells don't work correctly. So they can't produce the antibodies. They can't turn into plasma cells in these patients. Okay, so that's the big difference between these two. One of them, we have no B cells. One, we do have B cells. They just don't work correctly. One of the things to kind of remember here, medium low yield, is that common variable immunodeficiency is sometimes associated with increased risk of certain lymphomas, autoimmune disease, rheumatoid arthritis. And again, the same concept when we talked about the lymph node is going to be true here. Because we have B cells, but they're not functioning correctly, we're not going to see germinal centers. We're not going to see follicles that are going to be very active in general in these patients. We would expect to have very small follicles or absent follicles in a lymph node. But again, the paracortex should be untouched because paracortex is referring primarily to our T cells. And we'll talk about thymic aplasia here. I won't go into, all of the details here. I think it's just important to distinguish these. So let's just talk about how thymic aplasia is different from some of the other pathologies here. Now with thymic aplasia, we're primarily going to be talking not so much about the B cells, but the T cells in particular. And the reason we're talking about T cells is because the T cells are going to be maturing in the thymus, right? We talked about that. Now, the issue here, again, you can see by the name, thymic aplasia, right? We're not really going to have a thymus. So if I don't have a thymus, I'm going to have a problem generating mature T cells, right? Because this is where pre-T cells, right, we're going to go. Remember that whole physiology we talked about, the whole mechanism of negative selection, positive selection, all occurring in the thymus from the pre-T cells. So if I don't have a thymus, we're going to have some major issues with making functional T cells. Okay, and why does this happen? Why don't I have a thymus? The issue is that we're going to have defective third and fourth pharyngeal pouch development. So this goes back to some of the embryology that we've talked about before. Third and fourth pharyngeal pouch are going to be very much involved with thymus development as well as the development of the parathyroid gland. And remember, the parathyroid gland is primarily responsible for calcium and phosphate regulation. Okay, and we'll talk about this in more detail in the endocrine section. Again, I don't want to get kind of too off track. But the point here is if I have a patient that has very low T cells, but completely normal B cells, I might be going straight to thymic aplasia here. Now you might be saying, well, okay, well in SCID though, you can have very low T cells. And again, that's true, but the difference in thymic aplasia is they're going to kind of go on a little bit about this issue with the parathyroid, because remember, this pharyngeal pouch development is not only for the thymus, but also for the parathyroid. So if you have a patient that has hypocalcemia in the setting of extremely low T cell numbers, now you might really be pushed in the direction of thymic aplasia. And the way that some people remember this is catch 22. Okay, so 22 is referring to the chromosome deletion that's involved. Okay, so this is the deletion that causes this issue with the pharyngeal pouches. So that's chromosome 22, and then each one of these is a very specific kind of category of pathology. So the C, you can think of this as cardiac defects, specifically conotruncal defects. And we talked all about this in the cardiology videos when we talked about tetralogy of Fallot. We talked about truncus arteriosus, and those two are very classic. So if you have a patient that has tetralogy of Fallot, really low T cells, hypocalcemia, very classic for this thymic aplasia. The A stands for abnormal facies. And there's actually a variant of this. That's the velocardiofacial syndrome. And then the T, we've already talked about, that's going to be the thymic hypoplasia. The C is cleft palate. And the H here is going to be the hypocalcemia. And again, some of these questions, you have to integrate a couple concepts, but your radar should go up. We have two diseases now that we've talked about with T cell deficiencies. And they're quite different, right, between SCID and thymic aplasia. There's some very classic findings we would expect to see with thymic aplasia. And remember, they're not always just going to tell you the patient has hypocalcemia. Maybe they'll say they tapped the patient's cheek and they saw some twitching, for example, or they're testing for Trousseau sign using a manual blood pressure cuff, whatever it is. There's going to be some clue that tells you that this patient potentially has this electrolyte disturbance, but they might not come out and say it for a lot of these different things, so you have to be prepared for that as well. All right, and again, for the diagnostics, low T cells, like we talked about, this is going to be pretty similar to what we talked about with SCID. The difference is we're going to have some defect in the parathyroid hormone, the calcium, also some of the classic findings we talked about. There could be a heart murmur, abnormal facies, cleft palate, all would be more classic for thymic aplasia. And the other point is, if in SCID, you might see the B cells might also be very low, right? You might have absent CD19, 20, 21 on flow cytometry with absent CD3. That would be very classic for SCID. Not classic for thymic aplasia. The B cells should be working in thymic aplasia, which helps differentiate it from Bruton's common variable immunodeficiency, as well as some of the forms of SCID. So now that we kind of have some idea about the T cells and the B cells, let's talk specifically about the immunoglobulins. And I like having this organized in this way because remember, in the last video, when we had defects with the BTK gene in Bruton's A-gamma globulinemia, we had pretty much wiped out all of our immunoglobulins. And we also saw that in combined variable immunodeficiency, where we had defective B cell development, and we just wiped out all of our immunoglobulins. But here, the difference is we're not wiping out everything in a lot of these cases. We're just focusing on one or two immunoglobulins that are going to call our attention to this specific disease. So we have to be able to kind of distinguish these. Remember, if we have a global phenomena of immunoglobulins being very low, we are going to start to think more so about the B cells being involved, as that's going to be upstream from this whole process if we go back to the diagram on the last video. But let's focus on these immunoglobulins here. Let's start with IgA. So the big IgA pathology here is going to be selective IgA deficiency. And this is going to come up very classically in board questions when they try to transfuse a patient. They start to transfuse the patient, and all of a sudden the patient goes into anaphylactic shock, and they're thinking, well, what's going on? We just gave this patient some blood. Why are they kind of having this kind of reaction? And the idea here is these patients will have very low levels of IgA in the blood. And the reason they might have those low levels of IgA in the blood is because they have antibodies essentially against the IgA. And so if you go back to talking about your type 1 hypersensitivities here and talking about IgE, let's just say that I have some mast cell or some basophil here. We'll just say it's a mast cell. And again, my patient might have antibodies against their own IgA. Okay, and so if that's the case, then we're marking our own IgA for destruction. So this patient might have very low levels of IgA. Maybe our body destroyed all of the IgA because we have antibodies against it. Some of those antibodies might be an IgE antibody against IgA. So let's go back to kind of the basics here for a second and just explain what's going on. So let's just say, we have some mast cell, and remember, we also have IgE antibodies in our blood, right? So IgE antibodies, and we talked about, having like an anaphylactic reaction. So here's my IgE antibody. I have an FC portion that's kind of docked up against that mast cell, and then I have a Fab portion out here, and that Fab portion is essentially binding to an antigen. So let's just say there's some, something we're allergic to. It could be, maybe it's an antigen from a bee sting or from a drug that we took, potentially that that we have an allergy to, or maybe it's even something like peanuts, for example, right? Or it's something a shellfish. And anyway, the point is that antigen binds to this Fab portion and can cause cross-linking of the IgE here with other IgEs that are on the mast cell. And the big thing that we have to remember here is that these mast cells, in response to the binding of this antigen, they can degranulate. So they can drop all of the granules out into the blood, and this process can set off a very strong immunoresponse, particularly using things like histamine, right? And then this can cause anaphylaxis, right? Anaphylactic shock from this massive widespread vasodilation. What's different here is that instead of this antigen here causing this whole problem, maybe, like we said, it's something this patient's allergic to. Instead of this antigen here, the thing that's causing these mast cells to degranulate is actually going to be an IgA antibody. If this patient's given blood that has IgA antibodies in it, this IgA antibody will bind to this IgE antibody in the host, and that binding will cause degranulation of the mast cell. So that's why we say that this patient here, the host that's receiving the blood, has anti-IgA IgE. Now read this carefully. Anti-IgA. This antibody is anti-IgA. It's against IgA. It's an anti-IgA antibody. And what type of antibody is it? It's IgE. So it's an anti-IgA IgE antibody, okay? And again, these patients are essentially allergic to IgA antibodies. So that's why it's called selective IgA deficiency. So again, if you have a board question, they transfuse a patient, they go into anaphylactic shock. There's a lot of different transfusion reactions. This is the classic one that you want to think about in that scenario, and you have an immediate reaction. Now that's pretty severe, but if we're just talking about, illnesses that can come from this, the illnesses in and of themselves are not so severe, okay? The anaphylaxis obviously is very severe if we transfuse this patient blood with IgA antibodies, but in general, just from an infection perspective, remember IgA is primarily going to be in the mucosal lining. So whenever you see IgA, you could develop respiratory illnesses, diarrhea. The classic thing to remember though is giardia. When you have IgA deficiency, test writers love to ask about giardia because IgA is very involved with preventing infections, or at least fighting infections with giardia. The other thing that you can sometimes see here is celiac disease being very classically associated with IgA deficiency. Now remember, this is again where this gets tricky, where you want to know your isotypes. Sometimes when you test for celiac disease, there's different types of tissue transglutaminase antibodies. Okay, so this is the tissue transglutaminase. Okay, so when you suspect a patient has IgA, sometimes you test them for this antibody. Now, there's different types of the antibody you can test for. If you test a patient, right, a patient that has selective IgA deficiency, which is very much associated with celiac disease, if you test them for celiac disease using a tissue transglutaminase IgA antibody, well, guess what? That might come back negative, but maybe this patient actually has celiac disease. And the reason for that, remember, if this patient doesn't make IgA antibodies, right, they don't have any IgA antibodies, they're not going to have an IgA variant of tissue transglutaminase, right? It's going to come back negative no matter what, whether they have celiac disease or not. Okay, so that's going to be a false negative because that patient, we might think that they might not have tissue transglutaminase IgA antibodies because they don't have celiac disease, but in reality they do have it. They just don't have IgA because they also have selective IgA deficiency, which is very much associated with celiac disease. So just something to keep in mind. Now, in terms of the diagnostics here, again, of course, the big point is serum IgA is going to be low. Should your other antibodies be low? No, right? This is going to help you differentiate this from some of the other B cell disorders. Remember, if I knock out B cells, I'm going to essentially knock out all of my immunoglobulins like we talked about in the last video. But here, the other immunoglobulins are just fine. We're really just talking about IgA. All right, moving right along here to discuss hyper-IgM syndrome. So hyper-IgM syndrome actually makes a lot of sense. And the way to kind of just quickly get your mind around this is, remember, IgM is the only isotype of an immunoglobulin that does not require us to go through the class switching pathway. It helps you get to this pathology very quickly and the pathophys. Okay, so the classic defect is going to be the CD40 ligand receptor defect. So again, just going back to this here, in a healthy adult, we can see this T cell here, we see CD40 ligand, CD40, right? Remember, the CD40 ligand is usually going to be on the T cell, and the CD40 is usually going to be on the B cell. And so this is a co-receptor when we're going through activation of the B cell. By having that co-receptor there, we can get this patient to not only generate IgM antibodies, but also to generate IgG, IgA, IgE, IgD, right? So that's the concept. I need this CD40 ligand to undergo class switching. That's the point. Now, if I don't have that, then I have nothing for this B cell to bind to, and so I only make IgM because I can't get class switching. Remember, once that CD40 ligand binding occurs, the T cell can send over certain interleukins to determine what type of class switching we're going to undergo. But again, if I don't have this, right, I don't have class switching. That's the point. No CD40 ligand, no class switching. Now, I said before, how do I remember the different inheritance patterns here? Well, I don't remember anything that's autosomal recessive, but if something's X-linked recessive, X-linked dominant, or autosomal dominant, I want to know about it, right? So this is going to be one of those scenarios where you do want to remember that hyper-IgM syndrome is X-linked recessive, and this is going to fit right into the category with things like severe combined immunodeficiency. If we're talking about a defective interleukin-2 receptor, that's also X-linked recessive, as well as Bruton's agammaglobulinemia, which is also X-linked recessive. And childhood opportunistic affections, right? Opportunistic being infections we normally wouldn't expect to see. Right, pneumocystis is very classic, histoplasma, cryptosporidium. The other big one here that you want to remember is also going to be CMV. Okay, so these four are all going to be very classic in hyper-IgM syndrome. But the biggest thing is when they show you the diagnostics, you're going to see the IgM levels can be high, normal, but all of your other immunoglobulins are going to be pretty much deficient. Okay, and again, how do you differentiate this from common variable immunodeficiency and Bruton X-linked agammaglobulinemia? Well, again, you just look at the immunoglobulins. If all of the immunoglobulins are low, including IgM, well, then you're thinking more about a Bruton's or a combined variable immunodeficiency. But if the IgM is high or normal, now you're thinking more about a hyper-IgM. The issue is just class switching. It's that CD40 ligand binding that we're concerned about. So I just brought this table back from the last slide. So just a couple things here. If I have a T cell deficiency, right? So if I knock out my T cells, again, we're thinking it could be SCID and it could be thymic aplasia, right? This would be very classic, particularly if I had both B and T cells knocked out. I definitely want to start to think about SCID. Now, what about if I just have B cells knocked out? If I just knock out B cells, I might be thinking combined variable immunodeficiency or Bruton's X-linked agammaglobulinemia. Okay, so both of these would fall into this category. Now notice, when I knock out this upstream, everything downstream is affected, right? Now on here, I just told you that if we have selective IgA deficiency, we would just be knocking out the IgA here. So the only thing we're primarily going to be getting, and it's not just to say Giardia, but Giardia is the big one, but the point is we don't have IgA, so we're going to get mucosal infections. We're not going to have issues with IgM, IgE, or IgG if we just knock out IgA. So this is going to be selective IgA deficiency. Okay, so selective IgA deficiency. Now, in hyper-IgM syndrome, the issue is over here. It's class switching, right? So in hyper-IgM syndrome, the issue is just class switching. So I don't have IgG, I don't have IgE, I don't have IgA, but I do have IgM. Because the issue is here, everything upstream should be okay, right? And so that's kind of how you got to think about this. You got to see how upstream is my lesion, so to speak, even though it's not a lesion, but how upstream is the defect from what's actually going on, okay? And that's how you can kind of make sense of this. Okay, the last two on here, not quite as high yield. Hyper-IgE syndrome is sometimes gets confused with hyper-IgM. In hyper-IgE syndrome, sometimes called JOP syndrome, the issue is that we don't really have our T helper 17 cells. And remember, these cells are very much involved with getting neutrophils and macrophages macrophages to the site of chemotaxis. If we go back, initially when we talked about acute inflammation, we talked a lot about this. And the T helper 17 cells are very critical with that. So you do want to remember T helper 17 cells and impaired neutrophil chemotaxis. And again, this is going to be one of those situations where if I don't have neutrophils, right, when we talked about acute inflammatory response, we need our neutrophils to help generate that response as well as our macrophages. And so if I can't get them to the site of the infection, we're going to have, walled off infections, abscesses, but we're not going to have inflammation because I can't get the neutrophils to the site of infection. This sounds kind of similar to what we talked about with leukocyte adhesion deficiency, where I couldn't get neutrophils to the site of infection because they couldn't adhere, they couldn't bind to the site. In this situation, I just can't kind of get the signal to them to get them over to the site of an infection or whatever it might be. But the point is we don't have inflammation here. Kind of similar to leukocyte adhesion deficiency in the sense that in that situation we didn't have pus, which is pretty much what we're talking about here. We can't get the neutrophils and the macrophages to the site of infection. And the way this is sometimes differentiated, and you can see there's other features here, coarse facies, eczema, but the way that you want to differentiate this is, again, you want to look at the labs. In leukocyte adhesion deficiency, we talked about some classic presentations, okay, and I won't go into all the details here, but there are certain markers that you're looking for, like CD18 in leukocyte adhesion deficiency. Here, the diagnostics you're looking for are elevated IgE and eosinophils, which are very classic for this hyper IgE syndrome. And you can also see very low levels of interferon gamma. Now, there's really only two major diseases where you're going to see low levels of interferon gamma. This is going to be one of them. The second big one is going to be interleukin 12 receptor deficiency. Okay, that's going to be the other classic pathology. But I think for the purposes of hyper IgE syndrome, that's really what you have to know. It looks kind of similar to a leukocyte adhesion deficiency in some ways, but the key is that you're going to have high levels of IgE, high levels of eosinophils, and again, because I can't get macrophages to the site of infection, those macrophages need to bind to T cells at some point when they present their antigens, and to get activated, those macrophages often will have binding that will lead to interleukin 12 and interferon gamma being released. If I don't have those macrophages getting to the site of infection because of impaired chemotaxis, I'm going to have lower levels, I would expect, of interferon gamma. Okay, and this is all, again, remember, because I have low T helper 17 cells. And why does this occur? This occurs because there's a STAT3 mutation. Now, STAT3 is one of those genes that's going to help regulate cell growth. Okay, you don't need to really know any more than that. You do want to know that this is autosomal dominant. Remember, you want to remember the diseases that have the kind of more unusual inheritance patterns. So remember, hyper IgM, X-linked recessive, hyper IgE, autosomal dominant. Now, the last one on here is going to be Wiskott-Eldridge syndrome. This disease in particular we'll talk more about when we talk about the hematology oncology, because it relates to that section in that there's an involvement of the platelets. But when we're talking about just comparing some of these different diseases, this one comes up because it can be easily confused for some of the other ones on here. So Wiskott-Eldridge syndrome classic mutation is the WASP mutation. Again, another X-linked recessive, a lot of very unusual inheritance patterns here, most of which, when in doubt, are X-linked recessive with a couple exceptions. This mutation is essentially causing some defect in the cytoskeleton. Okay, so you also want to remember that there's a defect in the cytoskeleton. Like I said, we'll talk about this in greater detail probably in the hem-onc section, but because there's some defect in the cytoskeleton, when cells don't have the correct cytoskeleton and they try to kind of bind to each other to communicate, right? They have receptors here, but if the cytoskeleton isn't correct, right? If there's some defect in it, then when these cells try to communicate with each other, they're going to have some difficulty in doing so because the cytoskeleton isn't structured accordingly. So cell-to-cell interactions will be impaired. And the big thing that this calls our attention in immunology is impaired antigen presentation, right? We have so much communication between cells because we have to present antigens, right? We talked about that in pretty great detail. MHC1, MHC2, these are all used to present antigens. If I have impaired antigen presentation, now I'm going to have a really hard time generating immune responses. So these patients in general, because of the impaired antigen presentation, they'll classically have infections with encapsulated organisms, opportunistic infections, and a lot of this isn't really news compared to some of the other pathologies we talked about. This won't completely distinguish this disease for you. The thing that you really want to look for here is going to be the other classic findings here, and that's going to be eczema and purpura. Now, the purpura specifically is going to be classic because these patients have thrombocytopenia. This puts Wiskott-Eldridge syndrome in the category of these thrombocytopenic disorders like TTP, HUS, ITP, for example, and it makes you distinguish between them. If you're just thinking about this in immunology, if you have answer choices like the ones shown here, the way that you distinguish this is based on the thrombocytopenia though, because this is kind of the outlier. If you look at the immunoglobulins, the IgA and IgE will tend to be high, but the IgG and IgM will tend to be on the low side. So again, what I want you to focus on here when you're asked about Wiskott-Eldridge syndrome and they're giving you, immunoglobulin levels and that type of thing, look for the purpura and potentially the eczema. Okay, and the purpura is because of the thrombocytopenia. These patients are going to be higher bleeding risk, and the low platelets can also cause things like epistaxis, for example. These patients might have recurrent nosebleeds, again, in the setting of this eczema and these recurrent infections. That's going to be very classic for Wiskott-Eldridge syndrome. And also notice here the platelets, not only do we have thrombocytopenia, meaning we have low levels of platelets, but the platelets are going to be unusually small. The whole point of that, again, is because I have these defects in the cytoskeleton. And one of the classic infections you'll also see here when we're talking about these recurring infections is these patients will tend to have recurrent otitis media. Okay, that's also very classic for these patients. Now again, if you just look at the immunoglobulins here, this is kind of the one situation where I would say the immunoglobulins are somewhat non-specific. They don't tell you a lot of information, but you usually do see an elevation in IgE and potentially IgA also in the setting of Wiskott-Eldridge syndrome. So now let's take a couple minutes to talk about some of these additional variants. And again, if you understand what we've been talking about this whole time in terms of, the physiology going on with the immune system, then a lot of this is going to make sense. So going to interleukin-12 receptor deficiency, we kind of already hit on this when we talked about antigen-presenting cells activating macrophages. And so you can see here, again, we have our antigen-presenting cell. Okay, so this is our antigen-presenting cell. And remember, this antigen-presenting cell, it can present its antigens to T cells, right? So we have a T cell here that it's presenting its antigens to. And remember that this T cell here is typically going to be a naive T cell when this presentation happens. In other words, this T cell has never been exposed to this antigen. This antigen-presenting cell brings this antigen into the T cell, again, because it's an antigen-presenting cell. And the reason that I'm going through all of this is because if you understand this process, then you can understand what happens in interleukin-12 receptor deficiency. So the macrophage now is going to release interleukin-12, right? We talked about this before. So this macrophage releases interleukin-12 when this binding occurs. So interleukin-12 goes over to the T cell, and then the T cell, of course, if you're going to release interleukin-12, right, there's got to be a receptor here. So this T cell can bind this interleukin-12. Then what does the T cell do? Then the T cell says, okay, macrophage, I see what's going on. You want me to go down the T helper 1 pathway, right? You're basically telling me, this antigen presenting cell is telling this T cell, hey, I want you to become a T helper 1 cell. Why would it do that? Well, it's probably concerned about an intracellular type of organism. What is a classic bacteria that's an intracellular organism? That's going to be Mycobacteria tuberculosis, right? We've talked about this, a few times now. And so this macrophage is essentially saying, look, I want you to become a T helper 1 cell. Okay, so that's why it's releasing interleukin-12. Now, again, we have to have the interleukin-12 receptor, right? That receptor, the interleukin-12 receptor, so that we can even get this process to happen at all. Now, typically what the T cell will do in response to that is it will activate this macrophage and say, hey, you're doing a really good job here. Let's activate this macrophage so we can kick things off to fight off this pathogen. Okay, so it's going to activate this macrophage, which is what we see in tuberculosis, and it's going to do that primarily through the release of interferon gamma. Okay, again, and this is the whole process. If you understand this process, this should all make sense to you. So now what happens is, in this interleukin-12 receptor deficiency, if I knock out my receptor, right, I can't get this interleukin-12 to bind to the T cell. I can't get a T helper 1 response because I don't have this binding to stimulate the response, and I don't get interferon gamma released because this T cell never got that signal from the macrophage or from the antigen presenting cell, right? And so that's the whole concept. So again, if we look at this, interleukin-12 receptor deficiency, right? No interleukin-12 receptor. What do you see in these patients? Typically, there's going to be younger patients, typically, 2 to 3 months of age that present and they have disseminated TB. You can also see this, especially if it's in older patients, you can see this too with Pott's disease, right? Where you have the TB essentially kind of infiltrating the spine. But the idea is these patients are predisposed to an intracellular infections that normally would have been fought off with the T helper 1 response, going back to our T cell video. And the classic one here is going to be Mycobacteria. And again, how would you diagnose this? Well, look, interferon gamma is going to be low. This should make sense to you. Interferon gamma is low because we can't stimulate this process to occur. The mechanism is essentially broken pretty early on here here at this initial step. Okay, let's talk a little bit about chronic mucocutaneous candidiasis. And there's actually a lot we could talk about for this, but I don't want to get off of the road too much in terms of what we really want to focus on. What we really want to focus on is in board questions, what are the things that we're going to see that are going to call our attention to this? And it's pretty straightforward here. We're going to see recurring or refractory candidal infections, particularly mucocutaneous infections. What does that mean? I'm not talking about infections of the bloodstream, right? If you have endocarditis from Candida, for example, that's more of an issue with neutrophils. When Candida gets into the blood, that's a neutrophil issue. Okay, then you're thinking more of a neutropenia. That's going to be more of a hemonc thing, right, in general. But that's the way to think about it. If Candida's in the blood, that's a neutrophil problem. If Candida is infiltrating the skin or the oral mucosa or the esophagus, that's going to be more of an issue with the T cells themselves. And I'll explain this in a second when we look at this test here on the bottom. Normally in a board question, if they're asking about this disease, they're talking about very low levels of the RE protein. And I think we talked about this a little bit in the T cell video. Also, you want to remember this is going to be due to a defective interleukin 17 or interleukin 17 receptor. Some associations are made with this as well. And I'm not going to go through all the pathophys here to explain it because, like I said, it's just not as high yield. But the point is that we have a lower response to candidal antigens. Now, the way that this is sometimes diagnosed is we can inject candidal antigens into the skin, and what we're looking for is some kind of response. It's kind of similar to what we do when we do the TB skin test. And just to give you an idea of what we're talking about here, so when I inject these candidal antigens, I might get some of these antigens binding to T cell receptors. I might get some of them even potentially binding to macrophages. And the idea here is when there's this binding, we already talked about this whole process here, right? The antigen presenting cell can present the antigen. This T cell may or may not already be activated. And the point is these T cells will start to release interferon gamma, like we just talked about out here, the same mechanism where they're going to release interferon gamma, and then this interferon gamma is going to activate this resting macrophage. Like we just talked about here, that interferon gamma is going to get released, stimulate this macrophage to become activated, and that macrophage is then going to release cytokines that will eventually result in some induration here, right? Some bump on the skin. And that shows that this patient is able to essentially identify candidal infections, and we're able to make an immune response to that candidal infection. Now, if a patient has this test done and there's no induration, then we would be more concerned that this patient potentially is more susceptible to a candidal infection. So that's what happens here in chronic mucocutaneous candidiasis. Again, we would have an absent cutaneous reaction to candidal antigens because our body is not well equipped to fight candidal infections, and that's exactly the problem here. So let me ask you, just to add some layers to this, now that we know kind of some of the players involved, right? We have T cells involved that are going to be involved with activating macrophages. Let's just say that we had a patient that had SCID, right? So we talked about this already, severe combined immunodeficiency. So if I had a patient that had SCID and I gave them an injection with the candidal antigen test, what do you think would happen? Do you think this patient would get an induration of the skin? Right? And so the answer to that is no, right? These patients should not get indurations of the skin because these patients don't have T cells. So they are not able to initially bind the antigen to the T cell receptor to then get that T cell to eventually bind to a macrophage and then release interferon gamma to activate the macrophage so that we can get a localized inflammatory response and an induration of the skin. They don't have T cells, so this process breaks down very early. What about now if I had a patient with HIV? Okay, so if I had a patient with HIV, let's say they had a CD4 count of 700. Okay, I'm just making up a number. If I had a patient with HIV that has a CD4 count of 700, do you think that they would develop an induration of the skin? And the answer is they should, right? Because they have an adequate number of CD4 cells, right? 700. And so they are able to produce this response. So barring any other defects, right? They have CD4 cells that are able to help get this initial process going. Now, if I had a HIV patient, on the other hand, that let's say had a CD4 count of, 50, okay, so if I had a patient that had a CD4 count of 50, on the other hand, this patient would not be able to generate the appropriate induration or any induration at all because they have very few CD4 cells. So the cutoff, like we always say, CD4 count less than 200 is when you start to think about more of the immunocompromised state of an HIV patient, and that goes hand in hand with some of these tests as well. Now, last question. What about a patient that has Bruton's X-linked agammaglobulinemia? Okay, so I'm just going to put Bruton's up here. What about this patient? Will this patient have an induration? And again, you have to just think about it. When you're answering these questions, these are all questions that are integrating a lot of the knowledge that you have, right? And so you think about, okay, what's the problem with SCID? No T cells. What's the problem with HIV? No T cells, unless I have a high CD4 count, right? If I have a CD4 count less than 200, then I have very low T cells. That's the same problem with SCID, low T cells. If I have HIV, but I have normal T cells, maybe I'm being treated adequately, or I don't have severe disease, in that situation, I should have a normal response. In Bruton's, what's the problem? The problem is I don't have B cells. Okay, if I don't have B cells, will that prevent this process from happening? The answer is no, right? Because there's no B cells here, right? We have T cells that are binding to macrophages to have a localized inflammatory reaction to get an induration in the skin. There's no B cells anywhere. Now, B cells will be helpful for immunoglobulins, right? Things that we've already talked about, class switching, memory responses. But in this particular situation, it shouldn't have an effect. You should expect to have some induration with Bruton's as well, right? Because the T cells technically should be functioning in Bruton's X-linked agammaglobulinemia. Okay, last one, IPEX syndrome. So IPEX syndrome is due to a mutation in the FOXP3 gene. Now remember, we talked about this when we went through the T cell video. We said there's these certain cells, these are the regulatory T cells. Okay, so the regulatory T cells. And these regulatory T cells are going to kind of be the opposite of the inflammatory response. Essentially, these cells are trying to keep things under control. They don't want things to get out of control, is another way to think about it, right? They want to keep the inflammatory response in check. And so the way that they do this, these regulatory T cells, is they're going to release things like TGF-beta. Remember, TGF-beta is going to help kind of either cause chronic inflammation or kind of just slow the overall process of inflammation from happening. And the other substance they're going to release is interleukin 10. So both of these are going to kind of quiet down the immune response. And regulatory T cells are particularly effective in this if we have a response to our own cells, our own self-antigens. This is why we went through the process of negative selection to begin with. And these regulatory T cells are marked, right? So they're CD4 positive, CD25 positive, okay, that's particularly high yield, and they're FOXP3 positive. Okay, so this is kind of the classic markers. Now you can see CD4 positive on a lot of different cells, right? CD4 positive cells can turn into T helper 1, T helper 2 cells, but you can also get regulatory T cells from CD4 positive cells. That's the point. They're coming from that cell line. And the thing that distinguishes them really is going to be the CD25 positive and FOXP3 positive, which is actually all up here. So the point is, if you have a mutation in the FOXP3 gene, you might see a pretty significant drop-off of those T cells. In other words, those three markers telling you that this is regulatory T cells. The point here is other T cell lines should be intact. So if I did a candidal antigen test on a patient that has IPEX syndrome, we would expect to see an induration because other cell lines are intact. It's the regulatory T cells that are affected. What is the presentation like in IPEX syndrome? And I didn't put a ton on here because I wanted to kind of talk about it. But the first thing is it typically is going to present very early. Some of these different pathologies we talk about, it doesn't really present until, 6 months after we kind of lose mom's antibodies. But with IPEX syndrome, things are going to start off very early on because the issue isn't that we don't have antibodies, right? We have antibodies. We're able to make new antibodies. The issue is that our own T cells are not regulating the immune response. So we can actually have, T cells in our body attacking our own cells, and there's no one in to kind of stop things and prevent it from getting any further. And that's the point here. So if we're attacking our own cells, we're thinking more of an autoimmune phenomena. And if you just remember IPEX syndrome with autoimmune conditions, that can simplify this dramatically, right? Because you know that the regulatory T cells are defective because of this mutation. Now, the classic things that you'll see are things like type 1 diabetes, right? And that's, again, our own cells attacking the beta cells in the pancreas. You can think about things like thyroid disease. So it could be hyperthyroidism, hypothyroidism, right? Thyroid disease. And these patients can have things like autoimmune hemolytic anemia. They can have ITP, which we'll talk about all of this in the hem-onc section. You can see these patients with neutropenia as well. And that's because we're attacking our own cells. And like I said, no one is there to kind of keep things under control. And so in these infants, what you'll see is they might have failure to thrive. Okay, so these infants might have failure to thrive because our own cells are kind of doing a lot of the damage early on, and this can be dramatic in these early stages of organ development. So this was a really large chapter. What we have here is a table just to kind of review everything in one place so that it's a little bit more organized. But again, it's not so much about kind of memorizing a lot of the details. Sure, there are certain things that you have to understand. You have to just commit to memory. But overall, if you understand the processes that we talked about, you just have to know what is the problem, and then you can kind of make sense at the diagnostics and some of the associations too. So let's take a look at the first one. We talked about SCID, right? So SCID, remember the problem. What's the problem? That's the first thing, absent T cells. Okay, so if I have absent T cells, there's going to be certain markers I would see for for example, if I was testing this in flow cytometry, the big one would be CD3 positive, right? If I don't have CD3 positive, that's pretty much universal among T cells. I might also see very low CD4. I might see very low CD8 potentially, right? So those are other markers, but the big marker to know is CD3. And again, if I don't have T cells, I'm going to have an absent thymus, right? Or a very involuted thymus potentially in these younger patients that are going to be presenting with this. And the classic newborn screening that we talked about is testing for these T cell receptor excision circles. Okay, so classically in SCID, if you see low Tregs, you want to start to think that this potentially is the disease that they're hinting towards. And if we also have concomitant B cell dysfunction or absent B cells, we would also see drops in our serum immunoglobulins. Now, there are certain diseases in general that you really want to know the presentation for. It's going to kind of call your attention to it. In SCID, it's usually going to be at that 3 to 6 month mark, which is going to be pretty classic among a lot of these different diseases, where they'll start to show symptoms. And eventually they'll have failure to thrive, recurring opportunistic infections. Opportunistic infections, we talked about things like Candida, pneumocystis, CMV, would all be very classic in these patients. But again, this alone is not always going to get you to the answer of SCID. You're going to really have to understand the diagnostics and understand the problem. And then they might ask, what is the cause of this patient's problem? It could potentially be a interleukin-2 receptor, which we talked about, interleukin-2 being that growth receptor that's going to help immune cell growth, right? And that's going to be X-linked recessive, or adenosine deaminase deficiency, which would be more autosomal recessive. And then we also talked about RAG mutations, not as high yield. All right, and then we talked about Bruton A-gamma globulinemia. Again, this is going to be absent mature B cells. So if I don't have B cells in the bloodstream, right, I'm going to have very low levels of my B cell markers on flow cytometry, 19, 20, and 21. And because of that, I have low serum immunoglobulins. And the other key point here is that your T cells should be normal, right? The T cells should be normal. I shouldn't have low CD3 in Bruton's. Combined variable immunodeficiency, what's the difference between these two, right? The difference is here I have absent mature B cells. Here they're present, they're just dysfunctional B cells. Okay, so I have B cells in the blood, so I should have CD19, CD20, CD21 markers on flow cytometry, but the problem is they're dysfunctional. So I still will have a decrease in all of my immunoglobulins and a decrease in my plasma cells because I can't get these B cells to actually become activated to become plasma cells. And so the classic presentation here, this is one situation where you really want to know that the presentation is going to be in an older patient. Now, it doesn't have to be between 20 and 40 years old. It could be a 10-year-old and 8-year-old, but the point is these patients are going to have less severe disease because they have B cells. They just don't work quite right as opposed to not having any. And so these patients will just tend to present later because the disease is less severe than these patients in Bruton's and SCID, which will present a lot earlier, around that 3 to 6 month mark usually. Selective IgA deficiency, again, what's the problem? It's right there in the name. We don't have IgA. That's the selective, meaning it's just IgA, right? That's the only thing that's going to be low here. When we have low IgA, I want you to think about Giardia, mucosal infections, but the big thing, the highest yield thing to remember for this, and this is usually how it presents, is going to be an anaphylaxis to a blood transfusion. Okay, so a patient that just got a blood transfusion for whatever reason, all of a sudden immediately goes into anaphylaxis. That's a classic patient for this. Again, that's due to that anti-IgA IgE antibody that's causing that to happen. Also remember that these patients are going to have a false negative TTG IgA in the setting of celiac disease, which is often associated with selective IgA deficiency. And that's because they don't have IgA antibodies. So that test is going to appear negative. They could still have celiac disease. It's negative because they also have selective IgA deficiency, meaning they don't have any IgA antibody. Hyper-IgM syndrome, again, what's the problem? Impaired class switching. If I can't do class switching, right, which comes from that CD40 ligand binding, if I can't do this, then I'm not going to make any of the antibodies or the isotypes that come from class switching. I might still have IgM. I might be making more IgM because my body is trying to figure out what's going on, right? So it's just going to keep generating a response with IgM, but I'm not going to have any of the IgA, IgE, or IgG antibodies because I can't class switch. In hyper-IgE syndrome, the issue here is impaired neutrophil macrophage chemotaxis. So this is kind of like what we talked about with leukocyte adhesion deficiency. We're going to have lack of inflammation because the neutrophils are not getting the signal to come to a certain part of an infection or an area that should be having some level of acute inflammation. And because of that, we're not going to have a lot of inflammation, and we're also going to have some classic features here, coarse facies we talked about, eczema. And when we look at the labs, IgE is typically going to be elevated in hyper-IgE syndrome. IgE elevation, very concomitant with eosinophils being very high. Now, the other thing to remember here is the interferon gamma is often low. Now, don't confuse that with interleukin-12 receptor deficiency, which is typically going to present a little bit differently. Interleukin-12 receptor deficiency is going to present with disseminated tuberculosis in a very young patient usually, okay? And that's because of the reasons we already talked about. You're not going to get interferon gamma release if you don't have interleukin-12 receptors on your T cells, okay? Because they can't then stimulate and do that next step of activating the macrophages. And so we're kind of jumping around a little bit, but that's your interleukin-12 receptor deficiency. But I just want you to remember that when you're comparing these two. So when you see low interferon gamma, it could mean either one. You got to take, if they're giving you information about IgE and eosinophils and, lack of pus or abscess without inflammation, you might be thinking more hyper IgE syndrome. If they're telling you that this patient has recurring TB infections, for example, and they potentially are, not responding to a TB skin test, something like that, you might think more interleukin-12 receptor deficiency. All right, Wiskott-Eldridge syndrome, we'll talk about this one a little bit more in the hem-onc section, but again, you have to remember, what's the problem? The problem is impaired antigen presentation. That's because we have cytoskeletal defects that are going to kind of inhibit our cell signaling. Okay, and so if we have impaired antigen presentation, the classic things you'll see are some deviation in the immunoglobulins, but that's not what I'm really looking at. I might see that, okay, the IgM, the IgG is low, but that's kind of, in some ways non-specific when you're comparing these diseases. The thing that I'm really looking for with this disease is I'm looking for this patient to have thrombocytopenia and unusually small platelets. Now, you can see thrombocytopenia in diseases like IPEX syndrome, where you have some component of autoimmune disease, okay, where you start to kind of attack your platelets, and that's called immune thrombocytopenic purpura. We'll talk about that in the hem-onc section, but the thing that stands out here, though, in Wiskott-Eldridge syndrome is that the platelets are really, really small. And they're really small because we have cytoskeletal defects and impaired communication between cells. And so it makes these very unusually small platelets. Okay, so that's what I'm looking for. Now, if you have low platelets and they have some kind of defect potentially, the thing that you're looking for here is going to be purpura, easy bleeding. These patients might have epistaxis, recurring nosebleeds, very classic, or bleeding for a really long time after a cut, requiring them to go to the emergency room or something like that. That would be very classic for this Wiskott-Eldridge syndrome. Now, the other things you can see with it, you can see recurring infections, you can see eczema. Again, these are more non-specific in the setting of these diseases that we're talking about, though. Chronic mucocutaneous candidiasis, again, we already talked about this one being a poor response to candidal antigens. That's the point. So you can get these recurring infections, recurring mucocutaneous candidal infections. Again, they shouldn't be in the blood, right? You shouldn't have a candidal endocarditis unless we're talking about a neutropenic patient. And we're going to diagnose this by having an absent cutaneous reaction to candidal antigens. And we have IPEX syndrome here. And IPEX syndrome, remember, this is going to be your regulatory T cells, FOXP3, low levels of regulatory T cells. And so we kind of hit on this a little bit. And I didn't want to add too much in. Remember, this is going to present in infancy very early. And the polyendocrinopathy is really the big thing I want you to remember. I'll put that in red here. So polyendocrinopathy, because, that's going to make this stand out. So we're talking about things like hypothyroidism, hyperthyroidism. It could be either one very early in life. It could be pancreatic disease. These patients could have type 1 diabetes. All very classic. They also can have enteropathy, skin lesions, which are more, non-specific, especially the skin lesions. But again, the thing that just zooms you in on IPEX syndrome is going to be the low FOXP3, CD4, CD25 cells on flow cytometry. They're talking about T cells. The other T cells are working just fine, though. You still have a T cell response. It's just that the regulatory T cells are not functioning the way that they should. So hopefully this simplifies things. Again, first thing you always remember is what's the problem? Are they giving you any diagnostics? And then are there any key pieces of information in the presentation? And I think I highlighted most of the key things in red and in pink here in terms of what you really want to know in the presentation that's going to kind of zoom you in to that disease process. You have 15 seconds to pause the video, read the question, and then we'll go through the answer. You want to try to skim this thing one time and then really focus in on what you know. What are the key things that you know and what are they asking in the question, right? This is going to be the most important sentence. What are they asking in the question? Okay, so let's read through this. I'll walk you through it and kind of tell you, what are the big things that really should have jumped out at you here. So we got a 21-year-old male who's presenting to his primary care physician to establish care. He states that he has been suffering from rhinorrhea, intermittent headaches, and cough for the past 2 weeks. He reports that this is his 7th illness this year and states that he recently recovered from a prolonged course of watery diarrhea. So when you see something like this, again, 7th illness this year, kind of unusual, had a prolonged course of diarrhea, has these symptoms for 2 weeks, right? So a lot of different kind of recurring illnesses, right? Which is pretty consistent with potentially an immunocompromised state. This doesn't really help us because if you look at the answer options, they're all patients that have some immune dysfunction, right? Some immune deficiency. Okay, he states that he has recently had multiple episodes of prolonged nosebleeds. Okay, that's kind of interesting. Now we're kind of going in another direction. Which one of these is associated with epistaxis? Not any of them really, right? Or at least off the top of your head. You probably don't make that association, but we'll talk about that in a minute. Vaccinations are up to date. Now, this is another one that's kind of funny because sometimes they'll put in here, vaccinations are up to date. It's highly likely at some point somebody's going to test you on the fact that these patients, oh yeah, their vaccinations are up to date, but guess what? They're literally telling you they're immunocompromised. So does that really mean their vaccinations are up to date from, an immunogenicity perspective, right? Are they generating a good antibody response? They might not be, right? Because they're immunocompromised. So just because the vaccinations are up to date doesn't mean that this patient is completely vaccinated versus all the pathogens we would expect them to be vaccinated against. Okay, the patient denies any sick contacts. Past medical history and birth history are insignificant. Physical examination. This is actually pretty important. Past medical history and birth history are insignificant. I'll tell you why that is just because I've kind of skimmed these options already. We'll come back to this. Physical exam reveals increased nasal mucus secretions and maxillary sinus pressure to percussion. Kind of sounds like an episode of sinusitis here. Okay, it's kind of what this reminds me of. Multiple ecchymoses are noted on the upper and lower extremities. Okay, so this is going back to this prolonged nosebleeds. Now I'm kind of thinking, okay, is there a coagulopathy going on here, or is it a platelet disorder? The patient is subsequently referred to a hematologist and an immunologist for further evaluation. Diagnostic serum studies and flow cytometry results are shown below. Lymph node biopsy reveals reactive follicular hyperplasia. Anytime in a board question they give you a biopsy, especially for step 1, make sure that you really take the time to make sure you make it a point of emphasis, right? Because biopsies are usually confirmatory things, and there's a major reason they're telling you that most of the time. So reactive follicular hyperplasia. So this means that we have a lot of B cell action going on in the lymph nodes. Okay, which we would expect if we had certain infections and that sort of thing. Which of the following immunologic disorders is most consistent with this patient's presentation and diagnostic evaluation? All right, the hemoglobin looks okay. The leukocyte count, it's actually not super elevated, which is fine. I mean, patients can have sinusitis and not have a significant leukocytosis. Oh, but here we go. The platelet count, on the other hand, is actually quite low, 61,000, which is very consistent with some of the presentation findings of the ecchymoses, the prolonged nosebleeds, and the bleeding time is also prolonged. But the PT and PTT are normal. So we're going to talk a lot about all of this in the platelet section in hematology. This is pretty interesting, so we'll come back to this in a second. The immunoglobulin A level is also quite low here. So IgA level is pretty low. It's 4. The reference range 76 to 390. IgG level is also very low. IgM level is also very low. CD3 positive. So remember, CD3 positive is your T cells. So the T cells look okay. Or CD3, CD4 positive. Okay, so remember, CD3 is just like T cells, right? So CD3, CD4, these are specifically talking about the T cells that are CD4 positive, or usually things like the T helper cells, for example. Okay, so CD4 positive cells are also within the reference range, which is good. And our CD19 positive cells, which is going to be our B cells, are actually a bit low here. Okay, so just to kind of organize ourselves here, we've got a couple things going on. We've got a platelet problem. Okay, so we've got a platelet problem evidenced by we have an increased bleeding time and we have a low platelet count. So the bleeding time can go up if there's platelet dysfunction or if there's an issue with the platelet count, like a quantitative issue where we don't have enough platelets, or both. The platelet count is probably explaining why the bleeding time is elevated, which would explain the prolonged nosebleeds and the ecchymoses. Now, that doesn't seem directly related, at least not on first glance, to some of these other things. The T cells, okay, so the T cells are okay, right? The T cells are good. We know the CD3 positive and the CD4 positive cells, they're within the normal range. And the B cells, on the other hand, are low. Okay, so our B cells are also low, okay, which is interesting because, remember the lymph node biopsy, reactive follicular hyperplasia. What is going on here? We can see the answer is common variable immunodeficiency. So let's kind of just peel the layers back here really quickly. One of the most underrated things also is just looking at the age here when you're talking about these immunodeficiency syndromes, right? And we talked about this past medical birth history were insignificant. So, if they came at this question and they said that, this was a 6-month-old or a 3-month-old or a child with a really complicated, first year of life where they had a lot of recurring infections. Now I might be thinking about one of these two. in my differential, right? I might be thinking about SCID, I might be thinking of, which is severe combined immunodeficiency, I might be thinking about X-linked A-gamma globulinemia. So remember, the issue in severe combined immunodeficiency, which in my opinion is probably the highest yield of these 5 on the list, maybe up there with option B, but the point is with severe combined immunodeficiency, you're going to have low T cells, you're going to have low B cells. We can see here that the T cells are actually within the normal range. And usually, severe combined immunodeficiency tends to present around 3 to 7 months of age, right? When we start to lose mom's immunoglobulins, we really start to see some of these infections take hold. Now, you can still get this one to present in adulthood, though, right? This could still present in adulthood, but the fact that the T cells are normal here, that pretty much just argues against this. Is probably not the best option, because remember, the T and the B cells are generally affected in severe combined immunodeficiency, right? Combined meaning T and B cells. Okay, the X-linked A-gamma globulinemia, on the other hand, is really tough to differentiate from common variable immunodeficiency because they're very similar, right? The issue with the X-linked A-gamma globulinemia is we literally can't get these B cells out into the blood, right? Because we have that BTK gene defect. So in X-linked A-gamma globulinemia, the T cells are often normal, like we see here, but we have some low levels of B cells. Now, in general, X-linked A-gamma globulinemia will tend to have lower B cells than a patient with common variable immunodeficiency, but that's not like something you can hang your hat on. But what you can say is, look, this patient, for one, X-linked A-gamma globulinemia is probably going to be in an infant, or like I said, 3 to 7 months of age, not as likely presenting in a 21-year-old, right? Just now, a patient that's never really had B cells. It would be pretty unusual, especially with no other past medical history. But the other thing to consider is that this patient had a lymph node biopsy showing reactive follicular hyperplasia. Now remember, if you can't get B cells out into the blood, right, how are you going to get all these B cells to the lymph node? They're developed in the bone marrow. So usually, if you did a lymph node, I'll just do lymph node biopsy on a patient with X-linked A-gamma globulinemia, you would usually see absent germinal centers, right? So secondary follicle, remember the germinal center is the pale staining portion. You might even see absent primary follicles, because the issue is you literally don't have B cells in your systemic circulation or even in the lymphatics. And that's different from common variable immunodeficiency. The issue in common variable immunodeficiency, there's some defect that happens usually between 20 to 40 years of age where patients start to have, just defective B cells that aren't quite working the way that they should, and their plasma cell levels then drop because those B cells aren't being able to convert themselves back into plasma cells. And so in general, your plasma cell levels, right, are going to start to drop a little bit because your B cells just aren't working the way that they should. They may have worked normally, up until 21 years of age, as is the case with this patient, or even longer potentially, right? Common variable immunodeficiency usually presents between 20 to 40 years of age. Classically in board questions, it presents between 20 to 40 years of age, but it can present earlier, right? Notice that X-linked A-gamma globulinemia in a board question, it's almost always going to present a lot younger, and the lymph node biopsy should show absent tissue in these areas, because absent germinal centers and absent primary follicles, because you can't get the B cells out into the blood. Common variable immunodeficiency, the B cells are out there working for, some part of your life, but then they kind of get defective, and because of that, they can't convert to plasma cells. Now, plasma cells are also, just like your general B cells, a lot of plasma cells are also CD19 positive, right? Just like a lot of your naive B cells. And so because you have this lower level of plasma cells, because they're both CD19 positive, you can actually get the CD19 positive cells, or the B cells, to be a little bit lower in common variable immunodeficiency. But that's why I tell you that usually in X-linked A-gamma globulinemia, the B cell count will be a lot lower, because literally all of the B cells aren't working. Whereas in the case of common variable immunodeficiency, it's mostly the plasma cells that are the cells that aren't accounted for, so to speak. In any case, though, in common variable immunodeficiency, much like X-linked A-gamma globulinemia, T cells should be normal, and the B cells can be lower. They could also be normal, though, right? They could be normal also, for the reasons that we kind of just mentioned. Now, another thing we would do these lymph node biopsies for, if you saw some of the data that we see here, you might be a little concerned about lymphoma also. And so that's another reason why, a patient that has common variable immunodeficiency, we'd probably be doing a lymph node biopsy. All right, let's just walk through the other options here. Interleukin-12 receptor deficiency, from start to finish, doesn't really sound like a patient with interleukin-12 receptor deficiency. If we had a patient that just got a BCG vaccine, right, it's a live attenuated vaccine, and then the patient develops systemic mycobacterial tuberculosis or something like that, that would be very classic for interleukin-12 receptor deficiency. So just remember, the whole idea with this is you have some antigen presenting cells, say it's a macrophage here, and let's just say it interacts with the pathogen like Mycobacteria tuberculosis, for example. It presents that pathogen to T cell, and then essentially what happens is the macrophage says, hey, based on the type of pathogen I'm seeing here, I'm going to release interleukin 12. And remember, interleukin 12 will then stimulate this T cell, right? It'll stimulate this T cell to become a T helper 1 cell. And then the T helper 1 cell will then release interferon gamma, kind of stimulate that macrophage to help destroy the pathogen, or at least to wall off the pathogen, depending on what we're talking about. But in any case, the point is that you need this interleukin 12 to bind to an interleukin 12 receptor here on the T cell to make it a T helper 1 cell. Well, if you don't have that receptor, then you can release interleukin 12 all day, but those T cells are not going to become T helper 1 cells. And so remember, that's the point. And so again, it's usually pathogens that require this T helper 1 response that these patients will typically have a problem fighting off. But we don't really see enough detail to mention that. In fact, the derangements in the immunoglobulin levels would suggest otherwise, right? Especially there's a lot better answers and options here. Okay. Acquired immunodeficiency syndrome. So we're talking about AIDS with option B. Remember, AIDS has a couple defining features. Remember, this is the human immunodeficiency virus, right? HIV, which is a retroactive virus and preferentially infects CD4 positive. Target CD4